Good afternoon, everyone. Welcome to Ethics Grand Rounds. I know that people are still filtering into the webinar, but I'm going to begin so that we have plenty of time to talk about the important issues we have before us today. We are really delighted to have Professor Lawrence Gostin here with us today to talk about One Health, the inextricable links of human health, animal health, and the environment. Before I introduce our distinguished guest to you today, I'd like to just talk through some logistics for the session. Next slide, please. So if you have questions for our speaker today, please use the Q&A function to either ask your question or to pose a follow-up question to his answer. You can also use the Q&A function if you're having technical difficulties, and someone from the Center for Bioethics staff will assist you in that way. Please do not use the raise your hand function. We're not able to accommodate that during today's webinar. I should inform you that today's event is being recorded. It will be posted to the center's website, to our YouTube channel by early next week. So you can access it there. You can see the link here on the slide. We ask that you would fill out an evaluation for today's talk. We want to make it really easy for you to access that evaluation. So there are 3 ways to get to it. First, it will pop up in your web browser after the event if you'd like to take a few minutes and fill it out right away. It is also linked in the presentation details document that center staff has linked in the chat. So you're going to hear me say a lot about the presentation details document today. It's a handy compilation of all the information you need to know about how to manage during today's webinar. You can find a link to the evaluation in that presentation details document. You'll also receive an email after the event with a link to complete it. So whatever makes it most convenient for you, please use that method. But we do take very seriously your feedback on these events. Next slide, please. So let's talk about how to get credit for being here today. Health profession students here at the University of Minnesota can get interprofessional education credit for attendance today. You will need to complete the IPE reflection form that is linked in the presentation details document. And again, that's available in the chat. This is really only for U of M health profession students. If you are seeking continuing ed credits, you can request a certificate of attendance for CEUs. The form for that is also linked in the presentation details document. See, I told you that was a very handy document. And within a few days after the event, we'll respond with the certificates to be issued. I just have to note that by accrediting agency rules, you have to attend at least 75% of the event today in order to be able to be issued a certificate. Finally, biomedical engineering students, you can email your program staff, and the email address is there on the screen and also in the presentation details document. If you let them know that you attended today, they can help you to secure credit for your ethics requirement by attending. Next slide, please. I want to take a moment to thank our co-sponsors. We would not be able to reach all of you with our Ethics Grand Rounds webinars if we did not have these excellent partners. Every event that we host, we rely upon partners to help us. So our partners, our co-sponsor partners for today's event are the School of Public Health, the Center for Infectious Disease Research and Policy, the Center for Global Health and Social Responsibility, the Interdisciplinary Center for the Study of Global Change, the Institute on the Environment, the School of Nursing, the Medical School, and the College of Veterinary Medicine. It's really, I think, a testament to the interdisciplinary nature of this conversation that those are our partners, and they are really critical in helping us to reach our interdisciplinary audience. So we're very grateful for their assistance. Next slide, please. Okay, without further ado, then, I am going to introduce to you our distinguished speaker, Professor Lawrence Gostin. And as usual, I'm going to do a very brief introduction. You will find his full bio in the presentation details document in the chat, and I do invite you to review it. It's an impressive one indeed. Professor Lawrence Gostin is university professor at Georgetown University. The university professor is that institution's highest academic rank, which is conferred by the university president. He is also faculty director of the O'Neill Institute for National and Global Health Law and the founding O'Neill Chair in Global Health Law. In 2021, he received the Steve Goldberg Memorial Award for Community Service at Georgetown. He has worked extensively with the World Health Organization. And I think at this point, again, I'll invite you all to review Professor Gostin's fuller bio in the presentation details document in the chat. But at this point, I'll turn it over to you, Professor Gostin, so people can hear the person, they can hear from you because you're the person they came to see.
Thank you very much, Deb. I appreciate it. I'm going to look at the deep intersections between animals, the environment, health. And the way I'm going to try to frame this is first to give you one of the classic definitions of the One Health approach. I'm then going to provide a few illustrations. I'll turn to a problem that's been highly salient in the media recently, which are the origins of SARS-CoV-2, and talk a little bit about the origin story, because I think that fits in very nicely with the One Health approach. I'll then, widen it out to other current issues, particularly things that we've experienced now and in the recent past: COVID, mpox, polio, the currently circulating novel avian influenzas. I'll then move on to the drivers of pandemics, what causes them. And I'm going to use pandemics very loosely because it's got a technical term, but I'm going to talk about really the spread of novel pathogens. And then I'm going to move on to the international dimensions, and particularly two really important treaty activities that I've been closely involved with. One is the Global Biodiversity Treaty, and the second is the Pandemic Treaty that's being negotiated now by an intergovernmental negotiating body in Geneva at the World Health Organization, and I've been working very hard on that. And then I'll just conclude with some of the key issues involved in that treaty, and also involved in the current pandemic planning, mostly looking at equity, because while people think of equity as quite separate from the One Health approach, I think it's highly integrated. But I'm going to try to be as short as I can, because this is such a rich area. I think we're going to get a lot more out of our conversations after my formal talk. So, I thought I would just level the playing field in terms of a definition. There are many, many definitions of One Health. In fact, there was a very comprehensive definition of One Health in the conceptual zero draft of the Pandemic Treaty, which is then left and now gone from the Pandemic Treaty. And if you wanted to kind of have an idea of what that is, why don't I talk about it first? So the conceptual zero draft is very similar to the CDC's definition of One Health as an integrated, unified approach that aims to sustainably balance and optimize the health of people, animals, the environment, and ecosystems. It recognizes the health of humans, domestic and wild animals, plants, and wider environment, including ecosystems, are closely linked, closely interdependent. And the approach mobilizes multiple sectors, disciplines, and communities at various levels of society to work together to foster well-being and tackle common threats to health and ecosystems while addressing the collective need for clean water, energy, and air, safe and nutritious food, and taking action on climate change and contributing to sustainable development. That was really a very bold and broad statement. It's even more bold and broad than the CDC's current definition, which I won't read you because it's more than incorporated in the conceptual zero draft. But the interesting thing is that when the intergovernmental negotiating body issued its zero draft, it had a long section on One Health. But to give you an idea of the politics of this, when the zero draft just came out a few weeks ago, all of this rich definition was gone. And I think politically, this is extremely interesting and it's extraordinarily important. I had the occasion, just as the pandemic treaty was being developed, to be in Geneva, and I gave a talk on One Health to, I don't know, about 100 government representatives from around the world. And it was incredible, the political pushback that I got. And that indicates to me that what I call deep prevention is the One Health approach, is going to be a very hard sell in the pandemic treaty. I told the representatives there what I will tell you. It's really hard to get a binding commitment on One Health, but we all know it's important. We all know that this is what's driving pandemics today: climate, animals, and the intersection of ecosystems and humans. And so it may be that we'll never get to prevention, and we'll never get to One Health in international law, but we have to strive to do that. And that's one of the things I'm going to talk about at the end, about what proposals that I have with that regard. Another thing to talk about with One Health, and particularly at the both the national and the international level, is that it's inherently multisectorial. And so a Ministry of Health or the Department of Health and Human Services here in the United States, or CDC, certainly is important in the One Health approach, and they often take the lead. But you need multiple sectors, at the domestic level. You need health, you need the Department of the Environment, you need urban planning, you need energy, departments of energy, agriculture, departments of commerce. And we have the same siloed approach internationally. I mean, the World Health Organization has really quite tenuous relationships with the World Health Organization for Animal Health, or other agencies that are responsible for the environment. And so we have a deep problem of lack of this multidisciplinary and multisectorial approaches to health. We tend to be really in silos. And so I hope I've covered what One Health is. Essentially the the deep interconnections between animals, human health, ecosystems, and the environment. And I've also talked about the importance of multi-sectoral engagement in those. So that would be at different government departments, but it would also be different stakeholders and community representatives, and particularly civil society representatives that represent different interest groups, whether it be the right to health or climate change or animal health. For example, there's an international organization called Four Paws, which is a German-based organization, but here in the United States as well, which has been very active in the treaty negotiations. So we need all of those partners to get where we want to be. And so now I want to kind of step back and kind of give you some examples of where the One Health approach is not so much vocally stated, but clearly extraordinarily important to current debates. We've read a lot recently about the origins of SARS-CoV-2. And if you look at the congressional hearings that are taking place in the House, if you look at public opinion, if you look at what our spy agencies are saying, like the FBI or the Department of Energy, you might be forgiven for thinking that SARS-CoV-2 originated at the Wuhan Institute of Virology in China, in Hubei province. And the reason for that is that the SARS-CoV-2 origins debate has been highly politicized. And what I and many of my colleagues have been trying to explain is that it doesn't matter what the public believes. It doesn't matter what spy agencies say without evidence. What matters is, what does the science tell us? And the science tells us a kind of a deep problem of human and animal interchange. That would be true too if the lab theory were correct, but I've seen very little evidence of the lab theory. The idea of the lab theory is that they were working on novel coronaviruses with bats, that NIH had supplied funding through the EcoHealth Alliance to the Wuhan Institute of Virology, which was then doing enhancement research to enhance these bat viruses to make them into a SARS-CoV-2. That's a fascinating story, but I've seen very, very little evidence that that's actually how it originated. But had it originated that way, it would be an important story about the One Health approach. Clearly, wherever this virus originated, it's most likely to have originated in southern China in bat caves. Bats are a notorious notorious animals for harboring viruses, because they can have hundreds of pathogens in them and not get sick. But then they can also transmit it. The most likely explanation is for the SARS-CoV origins is the fact that it originated in the Wuhan wet market. The Wuhan wet market, as I'm going to talk about a little bit later, is a market that was essentially unregulated. It was selling both dead and live animals. There was very close animals in close proximity, both exotic wild animals and animals that are more domestic and more typically used for food, and there were humans. most likely there was a zoonotic spillover. That is that some animal in the Wuhan market then came into close contact with a human, and that virus then developed the capabilities for rapid human-to-human transmission. You may recall early in the pandemic that the World Health Organization, relying on Chinese data, said that it had no human-to-human transmission or very limited human-to-human transmission, maybe the way that current bird flus are. But all the evidence suggested otherwise, even at the time. Even my WeChat, which is similar to WhatsApp, my friends were telling me about a widespread community transmission, as well as health workers getting sick with novel SARS-like infections. And so this idea of a wet market, where there's very intense and close interchange between exotic animals, wild animals, domestic animals, and humans, was probably the reason for this spillover. It's interesting that if you look at the various drivers of, if you look at the various ways that zoonotic diseases spread, it's a veritable list of what we have today in our of the diseases that we know. It's things like COVID, monkeypox, Ebola, the current Marburg virus that's circulating in Africa. It includes SARS-1 and, of course, SARS-2. It includes MERS. It includes novel influenzas and a whole range of other infections that we're well used to. And so the origin story tells us this, but also the fact that until recently we had three public health emergencies of international concern: COVID, Mpox, polio, and now, of course, we've got bird flu, which is not has not been declared a public health emergency, but it's an example of a kind of virus that could, through genetic change and adaptation, one day become more transmissible human to human. So the ultimate fear of a zoonotic spillover is that you have a spillover of a pathogen that's both highly pathogenic, that is a much higher serious disease and death rate than we had with SARS-CoV-2, and also highly transmissible. In some ways, with SARS-CoV-2, we kind of dodged a bullet, and we dodged that bullet in a way that was not because it wasn't transmissible. It's probably the most transmissible pathogen on the planet, but because it hasn't been highly pathogenic, nowhere near, for example, the great influenza pandemic of 1918. So with that, I want to kind of move on to some of the pandemic drivers. What causes all of this? I should point out that, to begin with, that we're in an age of pandemics. I wrote a JAMA article about a year ago saying that we were in the age of pandemics, because the number of novel infections over the last 5 to 10 years, and projected over the coming 5 to 10 years, or 10 to 20 years, is that we're going to see a rapid acceleration of the number of novel diseases. And so while we used to think that pandemics were a once in a century event, if you look through history, the really bad pandemics, tended to be just once or twice, maybe 3 times every century. We're likely to see them more. And even if they don't become pandemics, they're going to become really serious drivers of outbreaks, epidemics, and possibly pandemics. And so what are the drivers? Well, one of them, of course, is deforestation. And connected to deforestation is the issue of mineral extraction and mining. Both of these activities strip the natural habitat. And when they strip the natural habitat, it means that wild animals lose their normal habitats, and they have to search further for a livable environment. And when they search further, they're moving to closer and closer to human populations. And once they do that, they may come into contact with humans. Humans might eat them, for example, monkey meat that we saw that might have been responsible for the spillover for the West African Ebola epidemic. And it brings animals and humans into closer contact. Climate change does this as well, because as we have diseases as we have animals that are losing their ability to find food and losing their ability to have drinking water, they will move and migrate to areas again near human populations. So you can see both, the ecosystems with deforestation and mineral extraction, as well as the problem of climate and having animals losing their ability to survive. It means they all come together much closer. We also find that there's, when they do come into contact with humans, there is a greater concentration of humans, humans congregating together, and humans congregating together with domestic animals as well, pets, and many, of course, populations have wild animals, exotic animals. Well, it's not common, but it's something that happens regularly in the United States and other places. So we're seeing an intense urbanization of our world. The World Health Organization has estimated that about 55% of the world's population now are in urban centers. And by 2050, it's suggested that it will be over 70% of the world's populations. And so you're going to see a greater concentration of humans, closer proximity to animal populations. And this is also true with domesticated animals. I talked about the idea of pets, but also there's the issue of intensive farming, which is extraordinarily important in the One Health story. If you look at how chickens or pigs or other domesticated animals are to try to produce food, you see a veritable hotbed for the spread of viruses. So just for example, you can have chickens in a coop, and then you'll have bird flu that might come from China through migrating flocks that come into contact with these domesticated, intensively farmed animals, which has become a huge problem. Connected to that, of course, is also antimicrobial resistance, because we tend, particularly with farming, but also with humans, to use microbials prophylactically, and so they begin to develop resistance to our common treatments. So another slice of this story is that we may be headed for a world where many of our antibiotics and our antiviral medications become less useful or not useful at all, that we might be going to second or third or fourth line antibiotics to treat infections, and ultimately it might be so extensively antimicrobial resistant that people die and there are no ways to save them. And then, of course, we've got migration, because once you have these spillovers, which are approximately about 65%, and some say up to 75% of all novel outbreaks in the world today, you then have a population that's highly mobile. It's highly mobile in two ways. Although people don't like the term globalization these days, globalization and is still increasing. There's a lot of nationalistic, populistic talk about, domestic production and so forth. But nonetheless, even with highly populist political leaders, we're actually seeing an advancement and an increase in migration and travel and commerce. Travel, trade, and commerce are extraordinarily important in rapidly propelling pathogens from one part of the globe to the other. The same thing is true with mass migrations. And mass migrations, of course, are also tied to climate change and food security. And so you start to see this very, very complex web of threats to human health that really cannot be solved other than through a One Health approach. Now I'd like to transition from the domestic to the international, and particularly international law. I talked a little bit about the domestic One Health approach that requires an all-of-government approach, a multi-sectoral approach. Although you see One Health in the United States, it's nowhere near to the kind of vision of One Health that one might aspire to. It has to be an all-of-government approach, and yet, if you look today, it's basically HHS and even CDC itself, one single agency that's leading the charge. And CDC doesn't have sufficiently close relationships with other key sectors to do with veterinarians, animal health, climate, and the like. We tend to still be in silos. There are two really transformational efforts that are going on globally. I've often said that this is, a once in a lifetime chance to do something big and bold. And I've, been spending, much of my time in Geneva recently working on these initiatives. And, my message to WHO, my message to treaty negotiators, my message to governments, my message to the White House is simply this. We're never going to have another chance at transformational change. This is really our one shot. We've got to be big and bold. And although people don't want to make firm global commitments to the One Health approach, I think we all know, and we all must know, that that's the only way that we're really going to get the kinds of health and security that we need. So what are these two international initiatives? One is the Global Biodiversity Treaty. And the Global Biodiversity Treaty is being negotiated because we've seen a really alarming and dramatic drop in biodiversity in species across the world. Every year, maybe even every week or month, we're losing species. And so we're becoming less diversified as a world. This threatens our land, our air, and our sea. And if we want to leave a healthy, safe, vibrant, robust, diverse, beautiful environment for our children and our grandchildren, we have to act now. The proposal in the Global Biodiversity Treaty is to set aside 35% of all the land and sea for as protected areas. That would be an enormous advance. It would help restore environmental balance. It would help ecosystems. It would help species to proliferate and to be protected. It would make our oceans much more sustainable, our air better to breathe, and it would cause enormous health benefits for our society, not just to mention the fact that we all live on this one planet, and it's a beautiful planet, and we want to leave that for our posterity. The second international agreement that's being negotiated, I've talked about. The World Health Organization calls it CA+. And basically CA+ is a convention agreement plus. And so currently, the negotiations are taking place under Article 21, but they could take place under Article 19 of the WHO Constitution. These are two articles. One of them is a convention, a framework convention, like the Framework Convention on Tobacco Control, which is the one that we're currently operating on the assumption that the pandemic treaty will be. The other is based upon the international health regulations. For the purposes of disclosing my conflicts, I'm the only American representative on the International Health Regulations Review Committee at the World Health Organization. So I've been advising government, the WHO and governments about how to reform the IHR. So it'll come under either Article 19 or 21. These two articles are almost unprecedented in international law because particularly the regulations, but even also the treaty, requires governments, it's kind of gives governments a very strong nudge to sign on. So for the regulations like the IHR, we have 196 states parties, which is unprecedented because states are automatically bound unless they opt out. That's why the United States is part of that. In terms of the treaty or the convention, countries do have to ratify it, but they have to give reasons why they will or won't ratify the treaty. And so that forces governments to at least act on the treaty. The United States, and I've talked closely with the White House on this, the Biden administration in particular is in a bind because it's very unlikely that any pandemic treaty would get through the Senate, 2/3 of the Senate. On the other hand, the Biden administration have been, somewhat reluctant in Geneva, but I would say highly constructive and wanting to find a way to do this. And so the lawyers, I'm working with the legal department at WHO, are trying to figure out ways to link the international health regulations, of which the United States and 196 members are parties, with the pandemic instrument and the One Health approach, which would be a really a great thing, I think, to have the United States directly at the table. And so we at the O'Neill Institute, where I work at Georgetown University, has been trying to make proposals on One Health for the intergovernmental negotiating body and WHO itself. What we did is propose a few things. One is a multi-sectoral, coordinated, interoperable, integrated One Health surveillance system, so that when we do our surveillance, we surveil not just human populations, but animal populations. We also suggest that the treaty require governments to adopt national One Health action plans on antimicrobial resistance and evidence-based, risk-informed implementation of infection prevention and control, both in the animal and the human populations. And we propose the following specific One Health evidence-backed actions at the global level that we hope will seep into the national and local level that would practically operationalize the One Health approach. Number one is regulating wildlife markets, wet markets, and trade. A substantial body of evidence demonstrates that regulating wildlife trade, that is the illegal or illicit or even licit trade in wildlife, needs to be strictly regulated or banned. Wet markets need to be banned or regulated, particularly commercial trade in birds and mammals for food, pets, and medicines, as well as wet markets like the Wuhan wet market. The new pandemic agreement could leverage infrastructure already in place on the Convention on International Trade in Endangered Species. And that would be a way to try to incorporate this idea of regulating wildlife trade as well as wildlife markets. The second is reversing or regulating deforestation. I would say reversing and regulating. Human-driven changes to land, such as deforestation, have resulted, as I've said, in enormous disruptions in animal populations. A recent analysis showed that more than 3.2 million records from several hundred ecological studies at sites around the world had shown that native forests had been destroyed. And that included also 143 mammals, such as bats, rodents, and various primates, where their landscape has been affected. Third is healthcare access and services for communities living close to wildlife. As I'm going to say in a minute, equity matters, and having resilient health systems that pay particular attention to the idea of vulnerable populations that are near in close habitation with wildlife is important, as well as populations that are more vulnerable to climate change, such as island populations and populations that don't have the finances to have the wherewithal to sustain it. Fourth is strengthening veterinary care and biosecurity, as well as biosurveillance. And the fifth is managing antibiotic use in worldwide agriculture, which is a subject that I've talked about. I want to end with equity, because my view is that even before COVID-19, the prevailing narrative was one of deep inequalities, social, economic, and health. Martin Luther King famously said that all inequalities are unconscionable, but health inequalities are the most unconscionable. The One Health approach is equity enhancing. While equity is commonly understood as the fair allocation of global public goods, for example, vaccines or treatments, the importance of land management, climate, and others really affects the most marginalized populations. And they disproportionately benefit, the One Health approach does, poorer populations. These include indigenous peoples, subsistence farmers living off the land, poor residents reliant on bushmeat or wild animals for food, and migrants that are fleeing from climate change and food shortages. To me, the pandemic treaty, if it does nothing else, needs to focus on equity. And it has two dimensions of equity. One is this equitable allocation, a fair allocation of global public goods like vaccines, treatments, diagnostics, ventilators, oxygen. But the other is adopting what we call a One Health deep prevention approach that would disproportionately benefit poor populations. So let me end by just simply saying that everyone knows, I think, now that the world is at the precipice. We just saw the Intergovernmental Climate Change Report that showed an alarming projected increase in global warming and change in temperatures. We've seen every year unprecedented, hurricanes, tornadoes, droughts, and events that have caused huge emergencies worldwide. We've seen increased deforestation and increased mining for rare minerals, as well as common minerals and petroleum. And we've seen an ever-increasing cascade of novel infections. This is a wake-up call for the world. And as we enter the fourth year of SARS-CoV-2, yet another such a prominent example of a zoonotic spillover, we really have only one option. And that option, I think, is to be bold. It may be expensive. It may be hard to get countries to do it, but this is our only shot. If we don't see something in the biodiversity treaty, if we don't see something in the climate change treaties, if we don't see something in the pandemic treaty, and if we don't act as a collective world community to protect our own health, our environment, our ecosystems, and our land and our sea and our air, we're in deep trouble. Everyone knows that. We just need to summon the political will, because now may be our last shot before we forget about all of the horrors that COVID-19 brought on the world community. So thank you very much for listening, and I'll turn it over to you, Deb, for questions and answers.
Thank you, Larry. You've just done a really beautiful job of weaving together some really complex.
A lot of stuff.
It's a lot of stuff. It's very complicated, but it was beautifully done, and a very sobering talk, I'll say. Let me start with a quick question about the One Health definition that you mentioned at the beginning, which you mentioned has been stripped out of the treaty. We have a questioner who's wondering if there is a way to access it. Is there a site to it somewhere that they can access that definition?
Yes, it's the conceptual zero draft of the Intergovernmental Negotiating Body. So if I can find it for you and send it to you, and actually I've got a PDF, I could send it to you, Deb. But basically, if they Google WHO website INB conceptual zero draft, of the, you'll get it. It's there on the WHO website.
Perfect.
But don't be confused by the zero draft, which is the more recent document.
Got it. Okay. Okay, good. Thank you so much for that.
Sure.
We have a questioner who says thank you and says your observations about the politicization of the concept are really insightful. Given decisions like health freedom, deaf fund versus Biden, do you think current politicization of One Health is similar to other periods in public health history, for example, over the UN right to health, Alma Ata, HIV, and LGBTQ advocacy, or is there something new and distinct here?
That's a question of judgment. And my judgment, yes, it's new and distinct. And, I've lived a long, long life. I've been in the field of, bioethics and public health and public health law, global health for so many years. I have never seen such an attack on science and public health and truth in my entire life. Truth used to at least matter. And we seem to be in a truthless world now where, and I don't really know how this happened, how we politicize things. I mean, I have an article in the current issue of Health Affairs, which is devoted entirely to COVID, which basically shows there have been well over 1,000 lawsuits challenging COVID measures, which include literally every measure that Biden has done has been struck down by the courts. Most of them have, or long delayed. And I can only think of one thing the Supreme Court has upheld, and only by 5-4, which is the CMS hospital vaccine requirements. Everything else has been struck down. And state legislatures have completely moved to a whole new dimension of basically removing and gutting emergency powers. Got a little editorial coming out in the next issue of Science next week, which basically asks, the question, we better be careful what we wish for. We're disempowering public health at a rapid rate, both in the courts and in the legislatures, the whole political body. But when the next pandemic hits, that's even more pathogenic and more scary, we're going to look to public health to protect us, and their hands are going to be tied behind their back. So no, I've never seen it. I mean, you've got hospitals that are kind of not delivering babies because of Dobbs. You've got hospitals that are being questioned for not providing ivermectin, which is not approved for the purpose by the FDA. You've just got a huge backlash. I've never seen it before. I don't know if you have, Deb.
No, I agree with you, Larry. I think you're right. And you're exactly right in terms of, I think, tying public health's hands at a time when there are looming additional, even worse pandemic threats than COVID. So we have a few questioners who want to hear a bit more about the proposed bodies or governmental or international entities that would oversee or enact a One Health approach. And there have been a few iterations of this question, but let me try to phrase it this way. I think you did a nice job in your talk of talking a bit about, what the structure of that would look like globally and here domestically as well. One questioner in particular asks, I think, a question which is really relevant and follows up on some of the things that you said, which is, how do we, what can we do to hold governments or international organizations accountable to sort of push for a One Health approach?
Accountability is really important.
Yes.
Of course, we're all world citizens, and it is our responsibility to protest, to demand, to vote, to try to push through these One Health approaches. But the truth is that at the national, but particularly the international level, there are very few levers for compliance, accountability, and transparency. So I didn't talk about this, but it's something that I should mention. That, you've got a dual problem with international legal instruments. I can think of the Nagoya Protocol, which I didn't talk about, the Biodiversity Treaty, the Pandemic Treaty. And the dual problems are this. One, there are really three problems, if I may go back a bit. One is, how bold are the norms? That is, are we requiring something that's meaningful and impactful? The second is, the more meaningful and impactful the norm, the fewer states that will sign on to it. And the third thing is that even if you have that norm in the treaty or that standard, there are precious few accountability mechanisms or compliance mechanisms. If you look at the entire pandemic treaty, there's only one discussion of accountability and compliance. And it's shocking what it does. And this, I'm getting a little technical here. It's asking a future conference of the parties to negotiate it. In other words, it's recognized that the pandemic treaty will be adopted, and I think it will be, without any compliance, and that the conference of the parties at post-adoption will try to negotiate what accountability measures there are. Well, the conference of the parties isn't even going to begin to meet until 2025. And then it will take them a year or two to negotiate and adopt the compliance measure, and they may never do it. We found that out with the FCTC. So in terms of compliance and accountability, I don't have a lot of confidence, but let's start with getting the treaty ratified. Let's start with really bold norms. And then I think it gives a greater sense of responsibility on the part of governments and a greater power to civil society to hold them to account.
Thanks. Let me synthesize a few questions about, our audience wants to often know what can we do. And I think that the question on accountability sort of touches on that, but just quickly in terms of a last question, is there a special role the bioethics community can play here, or the community of educators of new health professionals?
Yes, both of them. That's a great question. I actually don't think that the ethics community has really been engaged enough in all the things I've talked about. We still kind of go back to important things, but not terribly relevant to this in terms of, the doctor-patient relationship and, new technologies and how we should, what we should think about them. I mean, we need an ethical case for One Health. I've never seen a really bold, comprehensive ethical case for One Health. It would be really great to have that, to kind of show and use in the public sphere. I think that would be enormously helpful. And of course, training of health workers is really important, because health workers are really trained to deal with patients. They don't really think about animals, the environment, antimicrobial resistance, a whole range of other things. And so we need to have much closer connections between veterinarian and medical, human medicine. We need to have more connection to the environment and ecosystems, but definitely, at least in the animal-human world, both public health and healthcare, but mostly public health, needs to be much more closely aligned in its surveillance, preparedness, and response with agriculture, veterinarian, and other sectors that are critically important to the One Health approach.
Thank you. We're a little over time, so I'm going to have to cut the discussion off there. I think we could talk for a much longer time than this, but I am so grateful for your being here today. I agree with you that bioethics needs to attend more to these issues, which is exactly why we wanted to invite you. And so I'm delighted that you could join us, and I'm grateful for your taking the time. Let me just, before we close out, let our attendees today know that they can look forward to hearing from us some more about our April grand rounds, which will be on the equitable inclusion of persons with disabilities in research with Dr. Willianne de Cormier-Plosky from Harvard. And in May, our Unpacking Bedside Bioethics series, our own Dr. Jennifer Needle will be presenting on standards for surrogate decision-making. That's a very clinical ethics focused series. So look for more information about those events from us, and we hope to see you all there. And let me one last time say thank you, Larry. I very much appreciate your wisdom and your expertise and taking your time to share that with us today.
Well, thank you, Deb, and thanks to all of your team at the University of Minnesota and all of the people who attended. I appreciate it.